I'm joined today, as I have been on several occasions in the past, by Rob Shanks and Darren Chandler from Go-To Imaging. Welcome, guys. How are you two?
Thank you, Stephen. Yeah, very well, thanks.
Very well, thank you, Stephen. Good to be back.
Yeah. Well, it's interesting seeing how your business is developing. Obviously, the business of the MRI stuff, because I know you're now doing regular online courses in how to interpret MRIs, and you're offering a support service for people as well, aren't you? So, is that going well for you?
Yeah, we've been had a lot of requests now to do some one-to-one training. Plus, yes, that's right. So we are offering an ongoing support service now, whereby people become members of a closed Facebook group, so that we can then just give them ongoing support through their interpreting scans. They can post questions. They can look at little bite-sized updates and stuff that we put up and posts that we put out. So yeah, it's proving popular again, which is nice.
Well, I don't imagine anybody's in any doubt that that's a valuable service. We'll come back to it later, I know, because anybody who's looking at MRIs and referring for them probably needs some support from experts like yourselves. Anyway, we're going to be looking at cervical MRIs today, and I heard you two debating who was going to go first. So who's it going to be?
I think I want to kick off, and then Darren's going to follow quite soon after.
Okay. You've got this slide about why.
Yeah.
Why MRI? Yeah.
Absolutely. So I think last time we were on, we predominantly were talking about lumbar spine, and obviously, as manual therapists, musculoskeletal therapists, we see plenty of necks and cervicogenic pain. And yeah, again, because of some requests, we thought, well, this would be good to give a talk on cervical spine this time. So yeah, in terms of why, that's always the first question, isn't it? Why are you going to want to have a scan done of the neck? Well, the obvious ones really are people who have persistent pain that you can't quite get to the bottom of. You want to diagnose and know whether or not, you are within the realms of being able to treat them, whether they do need some sort of referral on. So kind of the common ones are cervicogenic pain. So they've got, pain in the neck that just, it will not go. And you want to know whether there's significant facet joint pathology, whether there's significant disc pathology as well. That could be the source of that pain that may need some other sort of intervention other than yourselves. And then following on from that, obviously, cervicogenic headaches is another big topic, and a certain percentage of headaches will be coming from the neck, whether that be facet joint referred pain, myofascial referred pain. And again, you want to know, the state of the patient's cervical spine for that. And then the other big category, obviously, is the radiculopathy pain. So the people who have the shooting pain down the arms, the nerve root entrapment, pins, needles, numbness, weakness even in the arms and hands.
Can I just ask you about the cervicogenic headaches business?
Yeah.
I just wanted to clarify, are you saying that this is a diagnostic tool to say, yes, there is a possibility that the cervical spine is the cause of the headaches? Or are you saying that having already worked out that they're cervicogenic, this might tell you what the actual cause is within the cervical spine?
So you cut out slightly there. So I think you were saying, are we using this as a diagnostic tool for the cervicogenic headaches? Is that
yeah, I mean, could you use the MRI to say, yes, and I can see why this is probably a cervicogenic headache? Or would you go to the MRI when you already suspect it's cervicogenic and look for the origin?
I think you have to be careful. You never pin your hat on just one test, and I think we also have to remember as well that a certain number of people are going to have degenerative conditions on their neck anyway, regardless of whether that's symptomatic or not. So as with anything you do, any intervention, any diagnosis you make, and any investigations you do, you always have to put that into context, and it's a judgment call, isn't it? So but let's say, for example, you had a patient who had very isolated pain to one side of the neck, and and you feeling the neck, you felt things were really degenerate and really and they'd have a history of trauma or whatever it would be. You would potentially want, and they're getting headaches on that side, you'd be asking yourself the question, well, do I think, could this be, a facet joint referred pain to the neck? If you then scan them, and if the scan comes back and it's clean as a whistle, you then perhaps are then taking that off the list rather than on the list. But the opposite to that would be they've got then a really raging isolated facet joint that's absolutely, different compared to the others, and it's right where you felt with your hands and your fingers were. Well, then you're kind of more inclined to think that is the cause of the headaches. But again, it's not a black and white thing. It's a judgment, I think, every time.
Sure.
And sometimes, sorry, Rob, but sometimes, Stephen, you would use the MRI to give you, like Rob says, just to clarify that there is potentially anatomical changes in that area. And if there is a hypertrophic facet, it would then lead us to then potentially go for maybe more imaging, like a SPECT CT, because some patients might have 5 or 4 facets which look grossly arthritic. And again, anatomically, yes, you see it, but it doesn't give you what one of them is the source. So we would then maybe go further and do a SPECT CT to highlight potentially the source then. So it's just kind of almost a category of testing and diagnostic examination to then go towards potentially the source of, you know, the pain in the long term. So
Okay.
yeah, it's just a tool, you know, that we're going to use.
Of course, yeah. So you've given us an overview here of cervical anatomy, which of course is quite important, because working out what's what on an MRI is far from clear, isn't it, to many of us?
Yeah, absolutely. And I think it's fair to say, interpreting images of the cervical spine, I would say, are slightly harder than the lumbar spine. I think that's a fair thing to say. I mean, you know, you have the same structure, you have discs, facet, you know, joints, nerves, muscles, all that sort of stuff. But there's slightly different, not rules that apply, but when you're going about looking at the images, I mean, on the previous lumbar spine courses we were teaching this, you know, kind of ABC approach in a certain order that you would go through for the easiest way of interpreting it. It is slightly different with the cervical spine, maybe the order which you go in, and in terms of looking at, for example, just giving you an example, a very good way of looking at the facets on a lumbar spine would be with the axial image. So what we're seeing here on the right hand side of the screen is an axial image, you know, sliced through the transverse plane. And then, like I say, the lumbar spine, you get a good idea of the facet joints pathology with that. But on the cervical spine, it's harder to interpret that facet joint pathology with the axial slice. And actually, probably what you want to do is maybe look at the, you know, the sort of parasagittal slices, the lengthway slices, and you'll see the facets in a slightly better way on the neck in those situations.
I should say, Rob, for all those people watching at the moment, that even with this full screen, it's going to be very hard for them to read this here. But in the handouts that we've got for you, your original slides, all of that will be much clearer. And yeah. But as you say, I'm looking at the facets in here, where that to me would have been much clearer on the lumbar spine. In fact, I wouldn't have even guessed that was the facet joint there.
Yeah, that's it. Yeah, so no, you're right. Yeah, the labelling there isn't as precise or as clear as it could have been, but as you say in the handout, it should be. So, but let's just do a quick little tour around this. So, obviously on the left hand side, what we're looking at here, you know, is a sagittal slice, mid sagittal slice in this case, right through the centre of the body. And as we've labelled there, the vertebra, the very top one that normally what you would see right at the top is actually C2. You know, that's the first kind of obvious lump of bone that you would see, if you like. So then you'd be counting down in terms of discs. You always got to remember that the first disc that you see is actually going to be the C2-3 disc. Okay, obviously because you've got the occipital lanceolate joint above. So then you're thinking in terms of the nerves which are coming out from that level. You've got C1 obviously starts above, and again you've got to remember you've got the 8 the 8 nerves in the leg, the 8 cervical nerve roots. So from above C2 you're going to have, you know, C1, 2, 3, 4, 5, 6, and then 7, and then C8. So just again, you've got to kind of get your head in gear for which nerves are passing by which disc. Now, also what we can see obviously is the bottom of the brainstem. You've got the spinal cord running down. Then, so that's that black kind of, you know, thick line, if you like, that's running down the centre is the spinal cord, and that's a very important part to look at, because for a lot of these central disc prolapses, for example, you want to know whether it's impinging on the spinal cord. Now, the white that's in front and behind that darker line there is the cerebrospinal fluid. So yes, you might have some indentations coming in towards that space, but the question really often on this sagittal slice is how much impact is it having on the cord, and also is there swelling around the cord? So at the moment we can see it's fairly dark. Now, if that was we had a disc protrusion that was pressing in and causing swelling, we'd then see some lighter shading almost around where it was indenting. So again, these are the couple of things which you want to look out for initially on these sagittal slices. And it's always nice, again, we'll perhaps, you know, maybe we'll go through some of the slices later, what we can see like we've done here, where you always want to try, if you can, and bringing up a sagittal slice next to an axial slice. And on the software that comes with the CDs, the MRI CDs, you'll often have the measuring tool where as you're scrolling through the transverse slices, you can see on the sagittal slide which level you're at. And that's always a very nice thing to try and get into the habit of using it when people are in the habit of looking at the patient's MRI scans, because obviously it orientates you as to exactly which vertebral level you're on.
Is there a default number of slices that they would usually apply in this?
Well, yes and no. So you'll find, as a general rule, you tend to find that the more expensive the scan, the smaller the slices are, if that makes, or the closer those slices are between each other, if that makes sense. Yeah. So it all comes down to time, doesn't it? Time is money, and money is time. So, you know, if you're going for the slightly cheaper end of the scans, they're trying to get you into the 20-minute, 30-minute slot, and they've only got a certain number of time to get a certain number of slices in. So yes, you can sometimes have situations where very subtle pathology is actually occurring between the slices and you haven't fully seen it. I mean, it's relatively rare, but you just, again, have to have that in the back of your mind as well. And bear in mind that, you know, one scan isn't always the same as another scan. And then that might be down to the number of slices. It might be down to the sequences that they've used. And again, we're going to talk about later on some of the actual sequences, things like stir sequences and coronal stirs.
Oh, I'm glad you said that, because somebody has sent me a question saying, please could you run through that, because he watched the previous ones and he's asking for a friend this time, he says. So Robin, I hope your friend will be satisfied with what you asked later on. He's not getting away with that. Go on, on you go, Rob.
So yeah, let's just quickly go through the actual slice there. So on the image on the right hand side now, so we're looking obviously through the middle of the neck, slice left to right, so this right hand side. And you know, your eye automatically would always go to the center of the image. So let's just talk about that initially. So obviously I mentioned the spinal cord, which again we're seeing in the middle there, that round kind of that's it exactly there. Thank you, Stephen. That's the spinal cord, and obviously then you have the sort of thecal sac and the fluid around the spinal cord, circumferentially around that area. And then immediately, if you like, in front on the 12 o'clock position, that you've got the vertebral body in this case, or depends on where you be, you know, it could be the vertebral body or it could be the disc, but this is where you'd be finding, you know, the disc, if it was protruding, either coming in centrally or coming in posterior laterally. And if you look at now the what's coming out, the structures that are almost coming out of the 10 o'clock and 2 o'clock position, these are the nerve roots. Okay, so where it says spinal ganglion on the label there, exactly that's where you'd be having the cervical nerve roots coming out from the sides that will be exiting, you know, down into the arms potentially. So depending on which level you're on. And again, you always want to be looking at, well, how is the space there, and how's the space on the left compared with the right? And remember that when we're looking at this, what's on the left is actually the patient's right, because we're always looking from the bottom upwards. Okay, so again, you have to just get that in your head. The left of the screen is actually the patient's right side. Okay, and obviously and vice versa. And then, as we've already said, the facets then are just sitting in, if you like, in front of, or you know, slightly lower than that, exactly there. That's it. So they're the facet joints in that transverse image. And again, they can encroach into that foramen as well. So they can cause that, you know, foraminal stenosis, as well as disc osteophyte bars coming in from above. You can have facet arthrosis coming in from the below as well. So there, you know, that's kind of what you're looking at, and often is a very important thing to look at when you're suspecting nerve root impingement. And then slightly further towards the back, obviously, if we orientate our anatomy, we have the spinous process coming down in that 6 o'clock position, absolutely. And then either side of that, obviously, we're going to have the cervical rectus spinae muscles, and again, they're also worth looking at. And you always want to think about not just looking at the spinal structures and the vertebral body and the spinal cord, but also take a moment with all these scans, really, just to look at the periphery as well, to see if there's anything going on in the periphery. And it's particularly in the lower, well, the lumbar spine particularly, you know, you can often see other things going on. So you can see, if you look for them, sometimes you'll spot kidney, you know, kidney stuff and that sort of thing. But obviously we're concentrating on the neck in terms of now. So the superficial structures, the peripheral structures, then, as I mentioned, you've got the trapezius muscles, the splenius capitis muscles right at the extremity. And then in front, we've got the laryngopharynx and the vertebral artery as well. Another important thing to think about there as well.
Well, a couple of things for you before you move on. When we are looking at the lumbar area, quite often you could see perhaps an imbalance in the the size of the psoas muscle. Do you attribute much weight to any imbalance in muscle size in cervical spine scans?
Yes. Again, for the same sort of reasons as we would look at the psoas. You know, you're looking at, you know, have they got, well, again, we're going to come through some slides later on where we'll see one of my patients who you know, did have a scoliotic posture with their necks, similar to what you might see in the lumbar spine. And again, you know, you do want to take a moment to think, well, you know, how does that muscle look compared with the other side? And, you know, is it in spasm, or is it, you know, atrophied, or exactly the same reasons you say that you would do for the yellow psoas muscle. It's also all information at the end of the day for us as musculoskeletal therapists. So yeah.
And this is jumping ahead just slightly. Franco has asked whether this is a T2 weighted scan.
Correct. Yeah. So these are both T2 weighted images. And again, just, you know, the reason why we know that is with T2, the way to think of it is T2 H2O water. So water is showing up as bright. Okay. So we know that on the T1 and the T2, the fat shows up bright. So we can see on the subcutaneous poster aspect of the sagittal image, we've got the subcutaneous fat, that's bright, but also we can see very clearly the cerebral spinal fluid around that cord area. So therefore, we know the cerebral spinal fluid is water, it's aqueous, so therefore the fact that it's so bright means it has to be a T2 image.
Yep.
And the same as on the axial as well. And obviously on a T1, that would be reversed, so where the water would be dark and the cord would be, you know, kind of the light of the two. And
the fat?
And the fat as well, yes. So with the T1 as well, the fat would also be bright. That's correct. So it's really, so the way to remember is this, don't get too obsessed with the fat initially, but just think about the water. The things that you're thinking of being water, as in the cerebral spinal fluid, what color is it? If it's bright or white, let's say, then it's a T2.
Okay. Right. So.
Okay. Right. Over to Darren. I think this is one of Darren's patients, so we'll let him do this one.
Yes. So what we have on the left on this screen, we're looking at a T2 sagittal on the left, and on the right, again, we're looking at T2 axials. So we have a professional dancer here who presented in clinic. They had a long-standing left-sided neck pain along with a C8 radiculopathy. So they had the classic tingling in the fifth digit, fourth digit, sort of running along the ulnar border, up under the arm. And they were getting a lot of discomfort, especially in flexion, you know, rotation to the left-hand side. So I sent her for an MRI scan. So again, as I think a lot of the viewers know, that the reason Robert and I got into this, because we sort of studied it under a couple of radiologists, and we started to just see so many differences in the style of reporting, and so many things were getting missed. So hence we started to run these courses and bringing up sort of talks like we are today. But this is just a classic, really, because if you look at the sagittal T2, if like what you see very top, where Rob was saying the first disc you see is C2. So the next one down would be C3, 4, then we've got C4, 5, and then we get to C5 and 6. And if you look closely, you'll see that there's a very, very small high signal. So there's a little bright bulge. I don't know if you can get your cursor to go along the back part of the, that's it, stop, just there. So you can see there's a very small bulge, and that's at the level of C5 and 6. Oops, we've gone back. So on the sagittal view, we see that there's a very, very small C5-6 bulge. And if you look at the one below, you can also see that the C6-7 also has a bulge as well. So we're looking at two very small discs, and they're contained annular protrusions. And we can see that because there's no high signal, the annular casing is still intact posteriorly. Now, if you look to the right of the screen, we're looking at two axials, as we say, and the top axial picture would be the C5-6, and the bottom one is C6 and 7. So can you see, if you look at the posterior aspect of the disc on C5 and 6, you will see that there is a little white line. I don't know if that's perfect. Just go a little bit higher. Let it stop there. So you'll see it almost looks like a hyper-intense white line, which is in the back of the annulus. And that would indicate that there is an annular tear. So it means that there's nuclear fluid inside the annulus, which would indicate that the nucleus pulposus has a slight crack, which is allowing that fluid to then leak into the annulus section. And there's a very, very small, and we would class this as a sort of paracentral left-sided bulge, because if you was to draw a line down the center aspect of that disc, you would say that the tear and the bulge is slightly more towards the left of the midline as you look at it. But you can clearly see that's perfect. But you can see also that the ovalness of the spinal cord has a slight little concavity to it, but there's no major compression, a very mild indentation due to that disc bulge. And because all of our viewers will know our anatomy, the C8 nerve root is not in that paracentral area or lateral recess. So if we're looking for a C8 radiculopathy, we're not going to see it at that segment. So we drop down a level and we go to the bottom axial view, and you can now see that at the level of C6 and 7, there is a slightly larger disc bulge. Perfect, Stephen. And you can see it's also hyperintense, which indicates that it's an annular tear. But there's no disc material outside of the annulus. Nothing has been breached. So we have two small annular protrusions coupled with two annular tears. But you can see at 6 and 7, there is slightly a little bit more indentation of the spinal cord, more or less the thecal sac rather than the spinal cord. So again, what nerve potentially would be compressed in that lateral recess area? It would be your descending C7, okay, at the C6 area as it comes out. So we also know that this can't really cause any C8 distribution numbness. So we got the radiologist's report, and if you go to the next screen, you will clearly see that the radiologist's conclusion was that there is only one mild disc bulge seen, and that's at the level of C5-6, which we've discussed. And this is causing the impingement of the thecal sac, i.e. the casing of the cord. But there is categorically no canal stenosis and there's no foraminal narrowing. So ultimately, this would decide that there's no nerve root impingement. So it kind of then gets the kind of practitioner or myself scratching the head. And then, as you can tell, we would then digress now and go over to potentially, you know, is there a C8 thoracic outlet issue here? Is the patient suffering with an ulnar nerve palsy? Is there an ulnar nerve entrapment at the elbow? So you can quickly see how you would start to change your diagnostic approach as such, or how you would then go into start testing other things. But if you bring up the next slide of that MRI scan, you will start to see that on the sagittal view on the left-hand side, where I've put the arrow, it looks completely normal. And you can see why the radiologist has missed it, because the back of that disc and the back of that annulus looks completely normal. It's well contained. But have a little look now on the right-hand side at the axial view. Now, first off, let's have a little look at the right-hand side of the lateral foramina. So I don't know if you can see at the back of the disc on the right-hand side. Well, as you look at the screen, we're going to be looking at the left-hand side of the screen. So if you can put your cursor, that's it, perfect. Now, between that cursor and the facet joint, if you come back a little bit to the edge of the facet joint, you can see come down, 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 to the left, left, stop. So there's the edge of your facet joint. So can you see there is a lovely canal between that edge of that disc and the beginning of the facet joint. So that is the lateral foramina on this patient's right-hand side. And that's giving free access to the exiting right nerve root, okay, the C8. But now let's look at the right-hand side of the screen, which would be the left-hand side of the patient. Can you clearly see here it is much more narrowed, okay? It's much more stenotic. And if you look at the corner of the disc with your cursor, can you see there's a black, go up a little bit for me? Stop, just there. To the left a little bit, stop. Just there is a piece of disc osteophyte bar. So that is a little piece of annulus / the end plate, just an osteophyte that has grown out towards the lateral foramina. And that, unfortunately, is going to occlude the hole, which again is going to affect the exiting nerve root at that level. So this patient has an obvious lateral left C8 nerve root impingement coming from a disc osteophyte bar. So I asked the consultant radiologist to take a second look, and the next slide will show the addendum to that. So here is his conclusion. There's evidence of cervical spondylotic changes at 3 disc levels. So it's interesting how when he was picked up on it, he then went from a 1 disc problem to now there's 3 disc problems. And he clearly states that the left C8 exiting nerve root is being impinged upon by a disc osteophyte bar. But, you know, and you can't really make this up. And as we've said on previous talks, we're seeing so much of this. And I think it's a disservice for the patient, because they're going round and round and seeing multiple practitioners because they're now being told it's an ulnar nerve entrapment, and they're having treatment with shockwave and laser and steroid injections at the epicondyle. And then they're having to have lots of treatment for the traps and the first rib and the clavicle because it's a thoracic outlet problem. When really all along the evidence was there, but obviously if you're not trained in looking at this kind of stuff, it gets missed. And it's kind of something we're seeing constantly. And I believe we're going to be talking in a week or two's time. And I saw a case last week that is so mind-boggling that the NHS have failed to sort of find. I will present it when we come on, in a week or two's time. But it's very similar. But it's just a big disservice to the patient, really.
Darren, I got some questions for you, if I can interrupt slightly. For Iqbal has asked 2. First of all, how old was the patient, the dancer we've been looking at?
The patient was 23.
Right. And he also said that the disc bulges that we saw here and there, he said they look really insignificant, and I think you covered this, but he probably sent the question in before you answered it. He's saying, is a disc bulge here likely to have more consequences than a similar sized bulge in the lumbar spine?
Do you know what? It depends, Stephen. I mean, it's an interesting question because this lady, she has 2 very small, insignificant disc protrusions. But, in some patients, these could be very painful. And because there is a tear present in both discs, if the tear is active, so we tend to talk about annular tears as being active tears and non-active tears. If you get an active tear, this person could be 10 out of 10 on the pain scale. But obviously for her, they were non-active, they were insignificant really. So yes, similarly in the lumbar spine, you can have this type of feature. It would be terribly painful for one, and yet for another, completely asymptomatic. So this is where what Rob was saying, clinically, you've got to be on your examination and to be able to correlate the 2 findings in order to make your judgment as to what the source of the pain is.
Yeah, I mean, my input on that would be in terms of if you want to have a little bit of a guidance as to kind of what you're looking at. You don't want to be just going on the size of the bulges. So it's not all about how big the bulge is. It's about really. Well, there's few categories we look at is what that bulge is interacting with. So you can have a relatively big bulge that's tolerated quite well if the patient has naturally has a large spinal canal dimension, or their foramen is quite large, or if the orientation, the particular direction which it's bulging isn't actually occluding anything. So and that will definitely vary. Just things like the spinal canal size can vary a lot in patients in the lumbar spine, and similarly in the neck as well. We all have different anatomy. We're all born with different size of vertebrae and hands and feet, but the same as your spine. So that's one thing. The second thing is also to look at you want to get this idea of wet and hard disc protrusions. So again, you can have a large nuclear extrusion or protrusion, let's call it, but the actual material that's bulging is largely made of water. It's the nucleus. Yes, it will give a very large, initial acute inflammatory reaction, but in terms of how compressive it is, it's nowhere near as compressive as those harder fibrocartilaginous annular protrusions, and they tend to be more chronic and they tend to be more compressive. So it's not just the size; it's the quality of that bulge, and also the relative size of those bulges to the neighbouring anatomy.
Not surprisingly, we've had a couple of questions about this specific patient. Kathy has said, "What is there a history of trauma?" And it occurred to me as you were talking about it. What's the etiological process for those osteophytes developing that you mentioned earlier on, causing that bar?
Yeah, it would be just increased wear and tear really over the segment. So being a dancer, this one was a particular break dancer. So there was a lot of, spinning on their head and lots of jumping up and down. So you'll generally find as the annulus and the disc bulges, then you'll get the end plates start to grow along the side of that disc. And then it forms these projections known as osteophytic spurs. And then hence, unfortunately for this patient, it has grown towards the foramina, where quite often they're far lateral, so it doesn't really affect anything. And they can be anterior in nature, and they grow forwards, and they can be massive, 2 to 3 centimeters in size. They're not a problem. But if they go towards the foramina, unfortunately, you then potentially run the risk of a nerve root impingement.
And just coming back to annular tears as well, specifically, Stephen, there's the general concepts now are that they're, one person's tear can be different to another person's tear just from a nerve ending point of view, from an innervation point of view. So the idea, this sort of new nervosum idea of different people have a different amount of nerve endings in the posterior structures of their disc, and also that can change over time in the same person as well. So you can have somebody who's potentially got an annular tear that then starts to become symptomatic because as I say, there's new nerve endings that start to grow in the area, and then they start to feel the pain.
Yeah, I don't know if any of you have heard of, there was a study, and I can't recall it. I know where I could get hold of it, but they did a study in Japan some years ago where they took 2,000 cadavers, and they counted how many pain sensory nerve endings, such as the sinovertebral nerve, were present at the posterior aspect of the L4 and L5 discs. And it worked out that in some they add up to about 4,000 to 5,000, and in others they add up to 60,000. So it kind of would tell us, although we've got 2 ears, 2 eyes, neurologically we're completely different. So one person's perception of pain can be completely different depending on the amount of neurons affecting the pain sensory pathways, etc. So the chemical irritation you get with an annular tear, it differs in so many people according to that neurology. So very difficult to say who is and who's not based on an actual scan. Again, it comes back to the clinical evaluation as well.
Yeah. Fionnula asked another question about the spinous process here. She's noticed that it's deviated to the patient's right, and whether you think that is a significant finding. Does it have any influence? Could you palpate it?
Again, there are various anomalies that you'll find, and it's that question of adaptation. Is it normal for the patient? Is it not normal? Is it their norm, depending on how you'll see on the left-hand side on the screen, on the sagittal, that this person has a relatively straightened cervical lordosis. The lordosis is absent in this patient. Now, is that the case because there's a muscle spasm due to the underlying issue? Has it become her norm? Is there a little bit of anterior wedging of the C5 disc, which is causing that microflexion? And is that then causing a problem with the rotation in that segment, which would then potentially cause a rotation of the spinous process? So you can see how you can go down a lot of roads. It may be, it may not be. But again, it's a good pick up. And yes, there's definitely a slight rotation there, but I would say you see this on many patients. And
you see it a lot. Yeah,
and you see it a lot in a lot of asymptomatic patients as well. So it's worth taking on board, especially if the patient's painful in that area.
We need to move on fairly soon, but just a couple more, if I may. Robin's asked whether you'd be able to see if the nucleus was sequestrated.
Yes, 100%. So on a sagittal and an axial view, you would see high signal, and the high signal would sit within the cerebral spinal fluid. It has a grey type appearance. So within the white area of the CSF, you would see a grey lobule. And if it's sequestrated, it generally goes, caudally or cephalad. It will kind of move up and down, and you'll see it sitting within the spinal canal.
And one, I suppose, which intrigues everybody here is someone calling themselves osteo has asked how your findings here would guide or otherwise govern your treatment of this patient.
Okay, so with me personally, I would be looking as an osteopath to massively concentrate locally at C7 and T1. I'd be looking to do a lot more localized traction with the patient. I would spend a lot less time with the patient prone, because that would tend to create more extension. So we'd close the foramina. So I'd treat this patient a lot more in a supine position with a lot of sideline to the right-hand side. So it opens up that left-hand side foramina. I would needle down a little bit more, maybe into those tissues. I'd just be a little bit more focused in my traction, distraction, and local soft tissue work in comparison to not having, for instance, you would spend a lot of time looking at the first rib and the clavicle and the traps if you felt it was a C8, impingement from that level. So it just hones you in more, I suppose, as an osteopath to work more local.
Well, I suppose the other thing is exactly as you said. The other way it's going to govern your treatment is that you won't be treating the elbow.
Exactly. Which a lot of others would if they didn't review this or they took the consultant's word for it.
Yeah. We've got some images of Damien here. Is this this is over to Robert?
So this is one of mine, and I just thought I'd put this in as it's slightly unusual in the sense that this is a relatively high. So most disc pathology happens around the C5, 6, C6, 7. It's a bit like the L4, 5, the L5S1 in the lumbar spine. But this chap here, so he's a is it 2, 3, 3, 4? Yeah, he's kind of 5, 6, but that's quite large, for what he's got going on there. And this is now, in contrast to the previous one, you can see how this protrusion is now encroaching on the spinal canal area, and also, in addition, a little bit over towards the patient's exiting nerve root on his left hand side. So it's a similar thing to the previous one, but it's just the protrusion a little bit more advanced, let's say. But the interesting thing about him, the reason I put this chap in, is this was post-traumatic. So this was he'd had a whiplash injury, and what we were keen to know is whether, well, he was quite keen to know is whether the whiplash injury had contributed to his symptoms. He was getting radicular pain down his arm, pins and needles, etc. And he had a previous scan. I think it had been 5 or 6 years before. So we were looking to see whether this was there 5 or 6 years ago or whether it wasn't. And what we found on the previous scan was that it was present, but it wasn't as big. So he did basically have some predisposing degenerative changes around this area. But on his most recent scan, he'd progressed to the point where you can see here on the left-hand image that back of the posterior aspect of the disc is actually abutting against the spinal cord now. It's kind of, actually, yeah, exactly. It's almost deforming it slightly. Not severely so, but it is still now looking like it's impinging on it, and similarly on the axial image. So, whereas on the previous scans that we'd seen, we could see that there was cerebral spinal fluid between those two structures. So it was, there wasn't, if you like, cord impingement. Now he hasn't got symptoms of cord impingement. He's, his lower extremity is fine, but he's one I'm keeping an eye on, certainly. And his main symptoms, as I say, were left-sided radicular pain. But it's a slightly unusual one in the sense that it's a little bit more severe, and it's just a little bit higher in terms of the disc, the disc spaces that we would normally see.
Rob, how old is this patient?
This chap is, I believe, that's a very good question. I think he's in his early 40s. I think he's 43, I believe.
And I'm assuming that this bright signal is subcutaneous fat here.
Yeah, he's a relatively large gentleman. Yeah. So
I was going to say that it's an unusual pattern. It looks a bit as though it would be a buffalo hump of some sort, if it were.
Yeah, he's got quite a lot of subcutaneous fat, this chap. But yeah, but that's what that is. Yeah, as you say, there was a previous patient that Darren was looking at, the dancer. You could see there was hardly any subcutaneous fat in that level. They were very slim, Yeah. So you kind of know about that before you send the patients into your scanner. So
here's a $60,000 question for you. Ellie has asked, should we ever take the consultant's word for it? I presume in this case she means the radiologist.
No, Elliot, no.
No, I think. Listen, I think it comes down to knowing your radiologist, and I think it comes down to being on your guard and trusting your own judgment, really. And look, take Darren's example that he put up there. He clinically found a C8 nerve root impingement, and he was convinced that there was one, even though the report said or didn't report it. Let's say so. He had a high instance of suspicion that the report was lacking something. And I think as long as you're there, and that's why we're so keen on people knowing how to and being prepared to look at their own scans, because you will pick this stuff up all the time. And that's not to say every single report's wrong. That's not what we're trying to say, but you just got to be on your guard, I think. And trust, as I say, trust your judgments.
Shall we move on and have a look at Jeremy?
Yeah. So Jeremy is it's a patient I've been caring for the last couple of weeks. And again, it's just a kind of relatively interesting one that I thought I'd put up. Now, the reason why I put this Jeremy up is because he has actually, well, this is another left-sided radicular pain. He's actually got a C7 distribution, this chap. So he'd been seeing some previous therapists who were basically treating him for essentially thoracic spine dysfunction. And the interesting thing with him is when I tested his reflexes and neurologically, he was okay. Actually, he had a triceps jerk was present. He wasn't complaining. He was complaining a slight little bit of numbness and tingling, but he was absolutely acute. I mean, as soon as he even attempted to side bend his neck to the left or to extend, the pain was down in the back of his arm. Oh God, he was really, really in agony. And it was all in the triceps area, and he kept complaining of his middle finger, like this pain and pins and needles going into his middle finger. So I was quite suspicious that he had a C7 radiculopathy, and he's actually been suffering for ever since the beginning of lockdown, and nobody had really got to the bottom of it in terms of diagnosis. So I said, look, let's send you for the scan, and let's see if we can see any evidence of that C7 radiculopathy. Now, what came back was quite interesting. Okay, so if we just count down the levels again. So starting on the left-hand side, we can see the top one is the C2-3 disc. Okay, so we've got C3-4, C5-6, C6-7, and then we've got the C8-T1. Okay.
The C4-5.
Sorry, I've done this count. Sorry, 2, 3, 3, 4, 4, 5, 5, 6, 6, 7. Sorry, yeah, right. So we're on the C6-7, and he was actually quite degenerate on this level on both sides. Now we're getting a hint of it if you look at the axial image on the right now, we're looking to see, well, can we see daylight on those exiting neural foramen? And actually, you'd have to say, an initial look, you actually say, do you know what? He looks worse. It looks worse on the right. So what's on the left of our screen, you can't see any daylight, and you can't. It looks like there's no nerve root space there at all. Now, I can tell you for a fact, he's at the moment anyway, he's got no pain on his right-hand side at all, no pain down his right arm. And the report that came back basically mentioned that he had foraminal stenosis on both sides, so left and the right. But as I say, symptomatically, it's all on the left. So, and now the reason why I'm mentioning this is because, again, it's not all just about the scan. So the scan is telling us, he's got potentially pain going down both arms, but he hasn't. In reality, he's only got pain down one arm. And this comes down to, various different reasons. It could be the way he's sleeping. It could be that the actual nerve root is more inflamed, more irritated on that left-hand side. He's potentially got more muscle spasm. There's a whole load of other reasons why he's symptomatic on that side and not the other. And we're picking up, yes, there's potential for it, but in reality, the patient was only symptomatic on one side. Now, the other thing, when you go back to that image, you've got to remember is as well that we're assuming that this is absolutely clean. This axial image is clean right through the middle of both foramen, and it might not be. We haven't got the benefit of having the live scan in front of us to go up and down the images. But partly what's going on here is that we're on the patient's left-hand side, the patient's right-hand side, we're kind of seeing a bit of a peduncle coming in before we're seeing it on the patient's left-hand side.
Yeah.
But what we can see, and what I suspect where he is getting his impingement from, is, again, the areas we've been pointing out on the previous scans. You can kind of see just move your cursor to the right a bit more there, Stephen. Yeah, so on the right again, that's it there. So, and just come down slightly. So there we've got this discus osteophyte bar here that is encroaching into that, just up very slightly to the grey area. Very slightly, there we go. So just that's it there, right on the edge. Now, what I'm interested then in the shading, so we're thinking to ourselves, well, how dark is it? How light is it? It's relatively, lighter compared with the sort of the body of the vertebral disc / body. So, we're starting to think this is, yes, it's an osteophyte bar, but it's it's not ultra hard. It hopefully is relatively malleable and squidgy. So with him, you know, I've actually have been now that I had this scan, I've now, a bit like Darren was saying, I've now started to focus my treatment really closely into this area. And you know, last week he's managed to get the first kind of full night's sleep that he's had for months, and that's simply from the benefit of me confirming, well, yes, that is what's happening. I'm not going to waste my time, you know, too much treating this thoracic spine or too many other things and thoracic outlets and inlets and all this stuff, and you know, angiotome referral from the thoracic spine, because I know that's where it's coming from. And when I focus that treatment to there, it is now, for the first time in several months, he's now starting to get a little bit of progress. But I've also got a plan in place that if he doesn't get there, he really is at his wit's end. He really is super acute, this guy. He's getting to the point where he can't sleep, you know, for very long, or had been. So my next plan is, if I can't turn him around very quick, I will be sending him for a second opinion and potentially for a nerve root injection onto that level to try and get him out of pain, to start to allow him to sleep a bit better, whilst at the same time probably still caring for him and treating him. Rob, so again, it's just about fine-tuning your treatment and your diagnosis and knowing what to do with the patients.
Rob, I can't believe that time flashes by so quickly. We've got loads of your slides left, including a quiz slide, I noticed, and we are out of time. I haven't asked all the questions that have come up on my list. If you don't mind, I'll send them to you after the show. And Elspeth, we will try and get the link to that research that Darren mentioned that you've asked for about the number of nerve roots in the disc and so on, number of nerve sensors in the disc. But that's actually all we've got time for today. I don't want to leave without just reminding people, and again, this is not a sales pitch at all, but it's just that I think your service is an incredibly valuable one that you're offering to teach people how to do this level of interpretation, and you're offering that support service as well. And that's all at gotoimaging.com or .co.uk?
.com, yeah.
Gotoimaging.com. But we'll put those links up, and of course the links will also be in the handout pack that comes with the recording of this when we post that, probably today or tomorrow. Darren, Rob, I'm sorry we've had to cut you short, but
no, fine.
It's gone 2 o'clock, and we promised that we do these things for 45 minutes. I'm sure we'll get you back in again because you're always very, very popular. But thanks for your time today. It's been great fun and very informative.
Thanks, Stephen. Great to be here. Thanks a lot.
Thank you.